All right. Well, welcome everyone. We are grateful that you're here with us this afternoon. I'm Kim Schuler. I'm the CEO for the Arkansas Behavioral Health Integration Network. And this is our third of 3 trainings this year on the collaborative care model. And so we have Dr. Verna Little back with us today, as well as Danny Hernandez from CFHA, who I know has a lot of experience with CoCM. And so with that, we are going to have lots of times for question and answer today. And we're also going to try and answer some of the questions that our FQHCs might still have and are bringing to us today. So, and Tisha wants to introduce her new BHCMs who are here. With that, I'm going to turn it over to Verna and Danny.
Wonderful. Well, thank you, everyone. Really excited to be here. I'm going to kick us off, and then Danny is actually a rock star. We should just call her Rockstar Danny. That's her nickname. And she's going to actually do a bit of a deep dive into some of the FQHC billing and has some slides to be able to answer some of those questions. So really wanted to make sure you had a chance to do that, because that was one of the things. And then also just bringing up a couple of other questions that came up, and then we can turn it over for some questions and then go ahead. I'll turn it over to Danny. And then I thought we would finish up today talking about psychiatric consultation in detail. Danny will set the stage a little. And then I actually thought we would do some role plays, because people asked, like, I really want to sort of see some of this in action. And so maybe we can try to end up doing some of those things. So a couple of questions that have come up that I wanted to just bring out. So one that was mentioned was around the time, and is a month billable if I don't actually talk to the patient? And so the answer is, I wouldn't do that for multiple months. However, if I, Kim gets assigned to me, and I look and I see that, she's just starting or has said that her medications aren't working. She has a high PHQ score. And so maybe I talk to the primary care provider to get some information. I bring her to psychiatric consultation because I want to make sure I'm, raising the flag and getting that done. And then I do an outreach to Kim, and maybe Kim doesn't pick up, and it's the end of the month and I don't get a chance to talk to Kim, right? Then that is actually, those are all billable activities. So would I do that multiple months? No. But sometimes maybe Kim picked up and it was the last day of the month and she said, I can talk next week, or I can talk tomorrow, right? So you're going to see some of those things where you've put in some time, but maybe haven't actually connected with the patient. And so that's okay to be able to do that, not as a rule, but as an exception. The other piece came up again around sort of care management and case management kinds of activities. Remember, collaborative care is the identification and treatment. So you're treating someone's mental health diagnosis. And so even though they use the term care manager, very specifically, again, those SDOH codes are not, activities are not included. So the housing, the food stamps, the disability, the transportation, all of those concrete services are not going to be included in sort of the billable activities. And we can sort of talk about some of those. So those are some questions that I remember coming up. And what else I'd like to put out, just questions to start us off that have come up in your practice, or things that have come up that we can answer before we kick over to Danny. I want to make sure you get all of your burning questions answered.
Feel free to shout them out or put them in the chat if you'd like, and we'll make sure they get read.
Everybody's got this collaborative care thing down.
I know we're so quiet. One question, and I wrote it down, but it's been a couple of weeks. So help me out, Misty, if I'm misremembering, but I think there was a question of if we submit a bill using these collaborative care codes and the bill is denied, do you have any guidance for that?
Yeah. So I would say 99.9% of the time, it's a problem filling out the claim form. Like the claim form got filled out wrong, because we really see very, very few denials in collaborative care. We see much less denials than we do for any of the other codes usually. Like you're normally, like for E&M codes, we say, oh, you know, we know 5% of them are going to get denied or something. We really see very few denials. What I would say is it's that, or there are some payers that if you put more than 2 494s, they will deny the whole claim. There are some that pay more than 2 99494s, but there are some that don't. And sometimes the ones that don't will deny the whole claim. Some of them will just not pay the additional 494s. Some of them will deny the whole claim. So that would be my second thing to be able to put. Sometimes it's because a 99494 went out by itself and not attached to like a 492 or 493. So those are really the top reasons that you see a denial. The only code that you'll see denied is the 99484. Anthem doesn't pay for it. But
Okay.
if you have a denial, feel free to reach out to me. Like if you look at it and it's not readily, you know, evident, then feel free to reach out to me. Let's look at the denial reason. Let's see how many you got. Let's problem solve it. I'm pretty sure we can problem solve it.
Awesome.
Long-winded answer. So the other thing I would say for my FQHC friends is, man, the universe was not kind to FQHCs and collaborative care codes, unfortunately. And Danny will talk a little bit more about it, but there are some payers, and I learned recently from United that they actually don't have it consistent. It varies from state to state, which blew me away. But some payers require the FQHCs to use the G codes like Medicare, and others have them use the CPT codes. And so if you get a denial, it is possible that that might be the reason as well if you're an FQHC. So nothing like making life complicated, but that actually might be the reason. I would say if I had the choice for my commercial plans, I would use the CPT codes because that's going to be the case most of the time. However, for your Medicare and your Medicare Advantage, you have no choice but to use the G codes. One of the big advocacy things that I'm going to try to take on is to get rid of the G codes for the FQHCs, like not just in the States, but even with CMS.
That's exciting, Verna.
Yeah,
Wow.
that it doesn't work and the time frame doesn't work. And Danny's going to get into the weeds here, but as you go forward, I'll actually be watching how all of you do and, you know, bringing it forward to be able to do that. And the Meadows is actually unveiling an FQHC report that they did in DC August 7th with me at that event.
I'll get into more of the weeds, Lavanya, and then I'm happy to send you the slides, or you can tell me exactly what you need after the fact and share that, and then you have Verna as a resource. So can't get any better than that.
Okay, thank you. I'll let Debbie know. Thanks.
I would also say too, as we think about billing, you know, I always think about there's two sort of pieces. One is the billers, right? How do we get it out the door? How does it look on the back end? But also it's important for the care managers to understand the billing because you need to know the times attached so that you're able to understand and look and say, wait a minute, I have these people that aren't billable yet this month. You know, is this included in the minutes? So I think it's important to have it from two sort of different angles.
Oh, okay.
What is one thing you wish every patient knew about collaborative care? So I feel like that's a little double-edged question because I never tell patients about collaborative care. I never tell them what it is. I never use the words, like, it doesn't matter. You know, like people just want to get better. And I think people have this idea that we have to say, we have collaborative care and it's this and it's that. And they use terms that we shouldn't use with collaborative care, like brief treatment. What is brief treatment? I don't even know what that is, right? But it's actually just jumping in and caring for people, right? So it looks like you've been sad for a long time. And, you know, tell me what's something you can do to feel less sad, right? Like, let's just go in and jump in. The average length of treatment in collaborative care is 6 to 8 months. And that's whether I saw someone at a community mental health center, on the street corner, in collaborative care, that's about what it would take if I really focused on someone's symptoms. And so I would really think about that. And when I think about PCPs, it's really important that they understand the difference between collaborative care and a traditional mental health referral, right? Because if I give someone a traditional mental health referral, they come once a week for therapy and that's the choice, and they get that or nothing. And it's kind of like sending our diabetics and saying, okay, Kim, you're a diabetic. You're going to go to the diabetes educator once a week for 45 minutes. Well, not every diabetic needs or wants a diabetes educator, right? Not every diabetic needs or wants to meet with someone every week for 45 minutes. Some need some nutritional counseling. Some need help around medications. Some need some goal setting to think about some lifestyle changes, right? And so now you have a behavioral health care manager that can be all things that someone with depression or anxiety needs. So think about one person who could be a diabetes educator, who could help with nutrition, who could help with lifestyle changes, who could do everything or all of those things or one of those things, and they could switch them up as that diabetic needed them. Well, it's the same thing with depression or anxiety. A behavioral health care manager is that one person who can give that broad range for patients with depression or anxiety. They can give talk treatment or traditional therapy. They can give, and for our folks on the phone who are not licensed, in scope is problem solving treatment, behavioral activation. Those are in scope for someone not licensed for the talk treatment, right? Medication support, goal setting, all of those things. So to be able to let providers know, often it's helpful to give them that analogy and then say, you know what, we've also learned a lot about behavioral health treatment, and it works better in doses, you know, like medication. We give people doses. And so what you need to say is, listen, I work with Khadijah and she helps me care for all of my patients who are feeling anxious. She's really funny. I think you're going to like her. I'm going to have her give you a call later today. And then I tell them, stop talking. And, you know, then that's all they need. And then Khadijah could say, hey, listen, I see you're starting a medication. It's really hard to take meds every day. Tell me about some times when you don't take the medication. Are there times when you take too much or too little of the medication, like on purpose? You know, what's something you could do today or tomorrow to feel less sad? Then Khadijah can just go in and start to care for that person, right? We don't need to talk to people about any of the, you know, sort of collaborative care specifics. So that really helps for primary care providers, for them really to understand the difference, if that was helpful to sort of think about it that way.
Part of what I'm hearing is maybe we don't need to be too worried about getting caught up in the specific jargon that might be hard for patients to understand, and put it in a simple, understandable way.
Yeah. I really don't start care with people telling them about collaborative care, telling how long it's going to last, telling them I talked to someone this morning and she was telling me, I tell people we're going to have brief check-ins. And I'm like, what is that? Like, you know, that's not, we don't need to know that. We're going to set a goal. I'd love to give you a call and see how that went for you, right? I don't need to tell you that's a brief check-in. I need to schedule a time. I need to follow up with you. Hey, Kim, how did it go for you to, you know, look in the closet and see if your sneakers were there? Oh, it went great. I found my sneakers and I also found my flip-flops I've been looking for 6 months, right? So like, you know, then you're having that conversation and setting another goal. I don't need to tell you that it's a brief check-in or that there's all these different treatment choices. It's kind of like if you were going to do traditional health, I wouldn't say, and now, Danny, we're going to do CBT, and then you would just do it. You would say, hey, wait a minute. You know, you would just reframe a cognition, or you would challenge something. Is it really true that people who are sad, we had a guy with traumatic brain injury this morning, paralyzed on the left side. And we asked him, we said, is it true that people who are paralyzed can't bring joy to other people? And he was like, well, no, I don't think that's true. And I was like, well, that's kind of what you were saying, right? So we sort of challenged that. We didn't tell him we were going to do CBT, right? And so I think that's kind of the thinking here. Just go in and have fun.
And Verda, you touched on this a little bit of the provider aspect, but what, and I see Danny will make their lives easier. We know that, but what would you say to providers who are struggling to get on board with using this model?
So so two things. One, I think it's helpful to have data. Here's all the patients you have that are on a depression or anxiety med. You have each provider probably has hundreds of them. And so I would say, here's all of the people. Now you have someone on your team that's gonna keep track of these folks. Are they taking their meds? Are the meds working? What symptoms are improving or what aren't? And if something isn't improving, you're going to not only know about it in specifics, but you're going to get some suggestions about what to do. And so now you really have, it's like someone giving you a right arm to help you manage all of these patients, and they're going to work alongside you, and they're going to make sure that you have all of the information you need on those patients. And you're going to know, if we're caring for Danny, you're going to know her sleep and her concentration actually got better on this medication, but she's not eating and the nausea hasn't gone away. And so it's been long enough now, it's not getting better. She's taking the medications. So here's a psychiatric consultation note to give you some information about a medication change that will help her nausea and will still give her the same results that you can try. And so now you have all of the details that you need.
Love that. Thank you.
Yeah, and make analogies. So what if every diabetic patient, every time they came in, you knew what their A1C was, you knew what their last sugar was, you knew how they were doing around their behavioral changes, you had some recommendations about what to do in terms of medications, you could see some goals that they had been set, you already knew if they had gained or lost weight and what was happening around that. You already knew that, you know, they had started Ozempic but didn't like to give a shot, and so they only do it every other week, right? Like you would know all of those things. How helpful would that be?
That would be awesome. And I just have to say, Verna, who could say no to another right arm?
Yeah, that's exactly, and especially at a time when they're so, you know, just not able to, I mean, they really have so much going on, you know?
Absolutely inundated with things.
Yeah, absolutely. And so I would say that that's, you know, a really important piece. So I'm gonna turn it over to Danny to do to Rockstar Danny. to do a super deep dive around some of the FQHC billing. So ask her all of the hard questions. Then she's going to transition a little, and then I'm going to come back. We're going to answer some questions, and we'll do some practice psychiatric consultation, and maybe we'll call out some of our new folks so they can get a chance to practice. So Danny, I'm going to turn it over to you.
Thanks.
So let me share my screen here, and Zoom has been funky with me when I share my screen with me. So tell me, can you still hear me?
Yes.
Yes. Okay, good. It worked. And you can see my screen. Okay. So, I don't know how deep in the weeds we want to get, but I'll get into some of the weeds, and feel free to tell me to fast forward or slow down by all means. And anyone else on the line, add your questions to the chat or come off mute if I miss it, because I only have so many screens here and just want to get all those answers, questions answered. So I wanted to just start with the very basics. CoCM is billed incident to. So what does this mean? Just so that we all are on the same page with what the CoCM codes, they're so unique and different from all the other services that behavioral health providers can provide, because this code is billed under the primary care provider. So Khadijah, Jennifer, as a behavioral health care manager, you don't have to worry about being credentialed. Are you in network or out of network with the insurance? Sometimes patients ask some of these questions, and you just tell them you're going to, however you pay or whatever your doctor is, in network, out of network, for your provider will be under the same thing. So it's an easy way to explain it to them, and that's why it's relevant for you. I came from a background of working in county mental health services. Before working with Verna, I didn't even know what CPT code was. Like, billing happened somewhere else and I had nothing to do with it. But patients have questions sometimes, so that's a good way for you to have that under your belt. I'm focusing here on the FQ, on the G codes. Like Verna said, FQs have a difficult time. There's more loops and hoops to jump through because of billing. One thing that you need to know is that there is a time threshold. So all the minutes over the course of the month are added up so that we bill once a month. Typically, when you have a visit at the doctor's office, every time a patient has an interaction with a doctor or any type of service, they are billed for that service for that time that day. Collaborative care is giving you a chunk of time, a total of 60 minutes for the month, and you're dosing that over the course of the month. For Misty, I can talk to her 2 times for 30 minutes in 1 month. And for Kim, I can talk to her twice a week for 7 to 10 minutes, and I am dosing it differently. A good example of some patients I've seen, at one time, I had one patient, she had actually a bipolar diagnosis, which you don't often find in collaborative care, but she hated the psychiatrist she was seeing, and the doctor said, I'll give her prescription. I just need a psychiatrist to let me know what to give her. This patient had been in psychotherapy. She knew more CBT interventions than I did. So I just needed to check in with her, make sure her meds are okay, called her twice a month for 30 minutes, golden. And then other patients that are feeling yucky or aren't able to get out of bed or are stressed because they're running around with kids and work. And you know what? They benefit more from a 10-minute check-in twice a week to see how they're doing. Did you go for that walk? Are you taking care of yourself? All those types of check-ins. How are the meds? Are you getting headaches after you take your medication? And that's a very different approach. So keeping in mind that you want to meet that total time threshold over the course of the month. Forget about how you dose it. You just want to make sure that you're getting to that time threshold so that you can be able to bill for the services you're providing. If we take a closer look at these codes, the G0512 is the CoCM code for FQs. The first month, the initiating month that you work with a patient, you need to meet that threshold of 70 minutes. They're adding an extra 10 minutes for that first month because they're saying We want to make sure you get all the information you need to initiate services. And then subsequent months, all the months after that first month, you just need to meet that 60-minute threshold. So that's including outreach, engagement with the patient. That's including doing the PHQ-9, talking to them about the PHQ-9 or the GAD-7. Like Verna said, developing those goals. Hey, what do you want to do? Do you want to make sure that you're getting out of bed every day? You at least want to open up the blinds, get going? How's your appetite? Whatever that treatment plan is for that patient, you're focusing on that with them. You're including that time with the psychiatrist, those recommendations that are being sent, any of those conversations you're having with the provider. To Verna's point, what she was talking about, how to get the providers on board, I would always tell them, I'm your eyes and ears. You're in and out of these exam rooms. These patients want to tell their story. Let me be your eyes and ears, and I'll come and give you the Cliff Notes version of it so you know how to work with your patients. And then tracking your registry. I have some screenshots. And when I used to tell my team, the last week of the month, I want you focusing on that registry. And if you have someone at 50 minutes, let's give them a call. Let's get those last 10 minutes in so that we can make sure we're giving them the appropriate interactions that they need for collaborative care and that we're able to bill for the service. And just providing those interactions. The G0511 is more of a code that is able to capture time for those patients that didn't fully engage in collaborative care for the whole month. Let's just say they got enrolled the last day of the month and they just could talk for about 20 minutes. This code captures that time that didn't necessarily fulfill the needs of collaborative care. Are we good so far? And I think this is mostly all for Khadijah and Jennifer, and if there's any other behavioral health care managers, I want you to think very broadly of what counts under CoCM and making sure that you're tracking your time appropriately, because there's a lot of work that happens. It's not just the work that's face-to-face or phone call to phone call with the patient. So all that assessment, that planning, all those interventions you're providing to the patient, that's included, all those surveys, all the interactions like the problem-solving therapy, motivational interviewing, and then all the behind the scenes stuff as well. So those conversations with your doctors, the conversations with a psychiatric consultant, checking your registry. Did Misty's PHQ-9 score go up this week? Let me call her again. What's going on? Let me check in on her. That's time that goes towards CoCM. One thing that I often found is that my behavioral health care managers would say, I just spent 5 minutes on it. I'm not going to document it. Well, 5 minutes times 4, 20 minutes. That's a big chunk of time over the course of the month. And then multiply that by however many patients you have, you're losing a lot of time there. And then you're wondering why you're so stressed out. So to my point, here's the supervisor role that's coming out. Document, document, document. It's not fun, but do it. It's going to help you out.
I had
Yeah, go for it.
questions. But I think you're answering it. The question was going to be if someone, not the initial month, but the month after had more than 60 minutes, are there additional codes that you can add? And it looks like you've got something here that might address that.
Yeah, so that's a good question. So with your G codes, no. If you're using the regular CPT codes, yes. We have the add-on codes that Verna was referring to, and that's usually where the denials might come in because either the claim was put in wrong or the insurance does not cover a lot of the add-on codes. Let me actually pull up something else and I have a better slide. Give me a second.
Oh, no worries. And then my other question was, so if you're an FQHC, and typically you would bill the G codes. However, I heard Verna say you could just bill the commercial codes. If you build those commercial CPT codes and you had over 60 minutes, would that be an allowable way to try to bill for the work that's been done?
I think it's worth a shot, and it's going to depend on the carrier or the insurance that you're billing. If it's Medicaid and an FQ, probably not. If it's a managed care plan or a commercial plan, then yes.
Okay.
So can you see this okay?
Yes.
Okay. So pardon me, I'm pulling slides from all over the place. So if we're looking at commercial non-FQs, here are your codes. These are your golden codes, right? Your 99492, 99493, and 99494. And then these are the time threshold doesn't have to meet the maximum. It can be half plus one. So if you look at the initial month, it can be anywhere between 36 to 70 minutes for the 99492. If you compare that to the G0512 for the FQs and the G code, the initial month has to be 70.
Mhm.
If you go up to 80 or let's just say 90 minutes on your initial month, if you're using the G code, you're not getting paid for the extra 20 minutes. Now, if you're using the CPT codes, you can do the 99492 for the first 70 and then do an add-on code of the 99494 for the extra 20. It's a lot of math.
And you can only use it twice a month or twice per
The
patient.
The average maximum, I mean, when I was working with Verna, we were adding like 5, 6, 99494s, right? Because there's some patients that like they need it. But if you're adding that much time, they probably need to be referred out. This is not the program for them.
Hmm.
On average, we've seen that most of the commercial payers cover up to 2 add-on codes per patient per month. So that's your either 99492 or 99493 plus 2 94s. And then I forget who it was that said they were from billing here, but make sure this is a little trick we learned too. Though that add-on code is on a separate line. Do not do 99492 times 2 on one line because that will get denied.
So let me ask, we have 2 FQHCs that we're working with.
Mhm.
Would you recommend that for Medicaid codes are not turned on in Arkansas? So for all patients that are not Medicare, they attempt to bill the CPT codes versus the G codes.
I would say go for it, but make sure that there's a system in place to go back and check for those and see what happened and be prepared to resubmit the G code or vice versa.
Okay.
If we can just submit 5 and see, like, just have a tracking system and it's going to take a while. That's the thing that you can't submit them and you get a response right away, unfortunately, right?
Yes.
So it's creating a system, either spreadsheet or note, like a calendar reminder. Hey, check for these patients and see what got approved, what got denied, and being able to track that as a team so that we can know how to drop those claims moving forward.
So I'm curious, I want to pause and ask the FQHCs, as you're hearing this and thinking about the codes and thinking about the different formulas and pathways, what are your ideas about using these different codes?
I'm just thinking it would be great if we had some sort of way that we could all communicate with each other about how we're getting things paid. Or it's relevant to the state of Arkansas.
You're right too, though. It is so difficult to go back, like, 3 months later, basically whenever it is, it's kind of just it being front and present. That's helpful, but having a way, I like the small sample size.
And like Verna said, we think we know it until a plan just like, oh, this is the way we do it. And then, like she said, United's like, oh no, we use these codes, not these. And they don't tell you up front. And it's even worse sometimes when you have the patients call and they say, oh, it's collaborative care, and then they send them to the mental health side of the, it's no one's talking to each other's. But if you can create a work group with yourself, have a sample size, sample group, make sure that you're checking back in 2 months, 3 months to at least analyze that and then be able to share out, get your best practices going for that.
Maybe the group coaching calls that we have, or even the monthly office hours that we've just started doing might be a great place to at least start doing that.
You're gonna have to prompt me because without a calendar invite, it doesn't exist.
What's that?
So you'll have to prompt me because without that calendar invite, it doesn't exist.
Not written down, I'm not doing it. That's all I need, right, Sadie? I feel you. I feel you. All right, here's a little pop quiz for you. Let me see. Oh, I gave you all the answers.
While you're pulling that up, Dr. Gibson had a good comment. Don't be afraid to call your payers too, to see what the result was, or if they will pay it or won't pay it. Because I know the billing folks have tons of extra time, but that is one way that you could do it.
Okay. Let me see if this works. So here's your CPT codes, right? Your CoCM codes. So if you have an initial month, you worked with the patient for 90 minutes and it's a non-FQHC, what codes would you use?
A 99492 and a 99494.
Perfect.
Oh, look. Okay.
All right. Initial month, 90 minutes at an FQHC, billing Medicare.
G0512.
Exactly. Good. Good. So essentially you bill the first 70, you're losing the extra 20 minutes you gave that patient. Fourth month, I haven't even talked about the G2214. I need to check with Verna if it's turned on in Arkansas or not. But actually, I'll just skip this one because I'm not sure. All right. So any other thoughts, questions on CoCM billing?
So let me just, and this is for myself, I just want to make sure I have a good understanding as we're moving forward. If typically, if I'm working in an FQHC, I will just have the two different codes that I'm billing. For the initial month, I could bill up to 70 minutes. For subsequent months, I could only bill 60 minutes. Anything after that, I'll probably lose the additional time because, as Verna said, they haven't been kind to FQHCs with allowing add-on codes. I just wanted to make sure I'm not misunderstanding.
That's correct. That's correct. If it sounds kind of not clinically appropriate or compassionate when you say you're not getting paid for this. Another way to reframe this
Sorry.
is and I'm just telling this for our providers, right? Because sometimes that feels icky for us saying, oh, it's all about money. But if you're providing more care than what is provided or is covered by collaborative care, it might be a signal to you that this patient might be in need of higher level of care. They might be in need of something else that is beyond the scope of what we can provide with collaborative care. Not that you can't handle it, not that you're not a capable clinician. It's just this is what is built for collaborative care. And we are probably doing a disservice to the patient by not being able to provide them with that higher level of care that they need and deserve.
Absolutely. That's so wonderful, that explanation. And then at that point, if someone, which a lot of these our FQHCs do, they have existing more traditional specialty care behavioral health models, they could potentially at that point move them over to that specialty setting to have the more intense services.
Exactly. And by the way, I'm out in California in a tiny little desert community by the Mexican border. So to say that services are like overwhelmed here, it's just the way that we exist here. What I would do often, like Khadijah, you get me as a patient, and I'm like, I am suffering here. I am having panic attacks, and I need to get into intensive trauma therapy. You know that for a fact, but the waiting list for therapy is 6 months. So, what could you do with me? You can engage with me, monitor me, start teaching me some self-regulating tools so that by in the 6 months, I'm on the waiting list. By the time I get to talk to my therapist, guess what? I am ready to tackle all that trauma therapy. I have my skills to self-regulate. I have my deep breathing. You're not addressing the core Pandora, like big old Pandora's box of problems I have, but I will be ready for it when my time comes up, to come off the waiting list. So, depending on the services available in your area and depending on waiting lists and stuff like that, that's another way to see COCM as a bridge to a higher level of care as well.
That's a really cool way to think about it. Any other thoughts on that from?
I have a question kind of going back over to the billing. Sorry to keep going back to that, but
Mhm.
our billers are obviously, billing departments everywhere are just busy. They're not sitting around twiddling their thumbs by any means. They're
Yeah.
busy. So one thing I think that we struggle with is just that setting up, that you're talking about the tracking and denials and submission. And that's something potentially that some of our support staff could assist the billers with, but we don't have any mechanism set up for collaboration with the billing. And I suspect it's just like everywhere else that any of us have ever worked. It's like, oh, the billing people, you just put in the code and then you don't give it another thought until they come back and tell you there's a problem. It's like, magic happens and you don't really know what that is, but you just assume it just happens. So is there any kind of set method of kind of setting up the collaboration? Like, how often should you meet? Should it be monthly? Should it be more often? What are some of the, I guess, best practices out there, if or does that exist for this?
Some of the more successful teams that I've seen do have a regular cadence meeting set up with leadership billing, at least one representative, just so that everyone's on the same page and they understand each other. And I agree with you. I think that every single team, no matter what area you're in, we're all running around like chickens without our heads or whatever. Everyone's busy and overwhelmed and stretched too thin. But I think that we can really facilitate understanding and reducing all these questions if we're able to communicate with each other on a regular basis, especially between clinics, like learning from each other and our experiences. What would be successful, nothing more often than a monthly, because you want to wait for those claims to come in, you want to wait for denials to come in so that you can talk about it and develop a plan for follow-up. And then I would highly recommend also making sure that you're tracking your samples claims. Not We're not just sending out, okay, these 5, we're dropping the CPT codes this month, making sure that someone's going to follow up with those in a couple months and not just losing that, so that we can make sure that we learn from it. But I'm not sure right now, you have coaching calls with Verna on a monthly basis?
They're actually having coaching calls with us on a monthly, twice a month.
Twice a month? Okay, so I mean, could it be possible to have one focused on like making sure that we have a standing billing time, bringing in claims, learning from that, and then, every time that they meet, so that they can make sure that that is being communicated and shared out and learning from each other?
I think that's a great idea. We've just started the monthly meetings. And so I think that that's a great piece. And as you said, it might take 2 or 3 months of submitting bills before we know what specifically is going to be paid for.
Yeah, we need some time to drop some codes. We need some time to get some responses and then just go from there.
And tricks such as
Okay.
Anthem's not going to pay for 99484s.
On
And,
the
and you know, those kinds of
Yeah, and just start tracking them. Have a shared document where you have all your payers and have your tip sheets created. Does that answer your question, Julie? I'm not giving you an answer, but I'm
No,
giving you.
absolutely. That's exactly. I mean, I love that idea because that's something, as I'm thinking through all this, I'm thinking, how do we make every component sustainable? And I had a wonderful conversation this morning with Kim about just sustainability with our training and education, but this is just another component. How do we, because the grant's wonderful, but how do we keep it going so that it doesn't just end in a few years? We're getting to this thing for the long haul, not just just for a short period of time. So how can you make that something that lives on and can benefit the community?
No, totally agree with you. It's funny you mentioned that, Julie. I'm working out here in California with some organizations from scratch, and the goal is sustainability. And they're like, "Oh no, we're just doing this for the pilot, and then we can't get it paid for." Like, why are you doing this work then? That's what we need to solve for. We want this to be weaved in to be part of the culture of your clinics. And if you're not making a profit, but at least sustain itself, right?
absolutely.
Absolutely. We live in a rural area and there's not a lot of money and patients don't have a lot of money, and that's the population we work with, and we love them. They're great people to work with, and it's, we want it to be meaningful.
Exactly, exactly.
I
And
also wanted to say at our last call, Verna had some great information on formulas on how many patients we might need on a caseload in order to make the program sustainable. And so I think circling back to those pieces, right, we have to know how much are we going to be reimbursed for these codes. And if we're primarily billing 160-minute code, and that's what the FQHC is getting paid for, that gives us an idea of how many visits need to happen and how many patients we need to have in order to sustain that individual salary after the grant ends.
yeah, so definitely leveraging those formulas, and also considering the severity of the patients that are being cared for. When I had staff that their caseloads can range anywhere from 50 to 55 patients to 120. Really big difference there. Um, but the ones that were doing 50 to 55 patients, they were, I mean, difficult, right? We're talking about psychosis and not always appropriate for collaborative care, but there's no other option. And they need more care, they need more time. And then there was others where I call them my viejitos, my little old people here in the desert, right? They just wanted someone to check in with them and help them get over to the senior center. And they were just happy to have a conversation and get their meds checked and, you know, do that. And they were easy peasy. And those were 120 patient case. So you want to not only calculate the formula for the income for how much you're going to need to get reimbursed to cover the salary of your folks, but also make sure that your behavioral health care manager isn't getting burnt out with 100 patients that are on Haldol, having psychosis episodes. Way too much. You're going to get burnt out along with not providing the appropriate care for the patient. So it's finding that right balance.
And then we had another question in the chat, Danny. Is there a list somewhere of diagnoses that are best suited for CoCM?
Yeah, so if we go to very true to the model collaborative care, we're talking depression and sprinkling in some anxiety, right? But more and more studies have shown that collaborative care is effective with a broader range of folks, including substance use. And obviously, I think that where we are and what's available to our community and the folks that we see really dictates what patients we're going to be seeing in collaborative care, right? So, what the ideal target population, and I'm not sure if your organizations are at the point where you're trying to decide and define the target population, but what we would typically use is any of your patients that are scoring 10 or above on the PHQ-9 or the GAD-7. So that's that mild to moderate range in the depression or anxiety. If they already have a standing diagnosis or a current diagnosis of depression and anxiety, or someone that has just started a new antidepressant, anti-anxiety medication, those are the folks that for sure you want to target for collaborative care. The folks that have something else like bipolar, schizophrenia, more complex dual diagnosis disorders, we can consider those for the bridging to other services, like I gave that example. Um, but it depends on where you want to go with your collaborative care and what caseload number you're aiming for, and because those patients are more complex. But definitely being able to target those depression, anxiety folks. Something else going back to your primary care providers is, can we pull some reports from your EHR, get that disease registry going, right? Do we have comorbid depression and diabetes, comorbid COPD and anxiety? Because guess what? If you can't breathe, you're gonna feel anxious, right? So can we get some of those COPD patients working with Khadijah to practice some deep breathing? Seems simple enough, but guess what? Here's your patients, right? This is a whole slew of folks that we can support, and your providers will be happy to get that support with those patients. And I'm sorry, Khadijah, I'm picking on you, but you're like right in front of my right in my screen.
And we got a comment that this slide was really helpful.
Okay.
And I think especially because we're starting out from scratch, right, with the CoCM programs. And so really looking for a defined target population as we start. And this might grow, and later we might be screening and adding additional populations, but starting with something like this, it sounds like is best.
I recommend that. Some places might be more ambitious, but I'm more of the line of thinking like, let's just figure out all the kinks. Let's go with what we know. And then, if we get more licensed folks, can we do a triage system? The BHCMs that are bachelor's level will take depression and anxiety. Licensed and independent licensed clinical folks can take more of the severe folks, kind of create a system after you have figured out the kinks in the workflow and the billing and have answered all those other questions as well. But I highly always recommend start with your PHQ-9 GAD-7, easy peasy, depression, anxiety, and go with that, and then just add to them after. Everyone back now? Is it safe to assume that folks are back?
Yes, let's go for it.
I will actually share, like, I don't know if you heard me, Julie, but I have tons of slides here, so I'm just gonna flip through them and answer your question, and we'll flip back if someone else has a different question. So if we look at collaborative care and look at it from the patient's perspective, the patient journey, this is just a sample workflow that I created starting from patient arriving for an appointment, identifying that they need services, and the behavioral health care manager engaging, right? So once, let me forward this. Once the provider says, hey, Kim needs the behavioral health care manager to come in, what the behavioral health care managers are going to be doing is pre-screening, looking at that chart, right? You want to get that information going, understanding what's going on so that they can guide that conversation and kind of, lead the way um, when they're having that conversation with the patient. Why do we want this screening? One, we want to get those baselines PHQ-9 and GAD scores so that we can know where the patient is. Are they scoring at a 12? Okay, you qualify, right, within our parameters. Or are you really struggling with your medications and just having a knowledge of what's going on? Also, you want to know if there's any risk here, right? If we need to intervene, develop a safety plan, that sort of stuff to make sure that the patient's safe. I'm getting to your question though. So when you're asking questions of the patient, you want to have an assessment. I really don't like using the word assessment because it has a really deeper connotation of therapy. We're not doing a full biopsychosocial assessment that you would in therapy. Um, and I come from a county system. Mine were 90 minutes and I hated them. And I even had to do genograms. We don't want that, right? We just want to get a good overview of what the patient is struggling with. And if you see here on my example, we're asking about psychosis, hallucinations, mood stabilizers. Typically, these would be an indication of a patient needing to be referred out to a higher level of care, right? So we're asking those questions to help us sort it out. So if you do want to consider a higher level of care, it would be those folks that have a severe substance use disorder. Is it a complex issue? Do they have active psychosis? I recall my patients where I had one staring behind me and I would say, what are you looking at? It's like, oh, you have the happy face dancing around you because you're so nice. That's someone maybe we want to refer out, right? Khadijah, I don't know if you want to work with them. Severe developmental disabilities, can we help them cope with this? Do they need linkage to other services? Can we bridge them? Figuring that out. And bipolar, I always bring this up. I gave you the example of my bipolar patient that I had to begin with. Amazing. She did well, but there's different needs, right, for each type of patient. So I hope this answers your question in terms of what you're considering in terms of referring out, bridging, or this too much care, right? We're talking about Verna earlier, how many add-on codes can we do? And if you're working with a patient for 4 or 5 hours per month, maybe they need a bit more care than what we can provide, and you're not going to be reimbursed for all that time anyways. So
Yeah. Or you're
Yeah.
spending too much time. Like a lot of times,
Mhm.
if you're doing, 45 minutes a week or an hour a week, and you're doing psych consultation and you're doing, you're going to go over that time frame.
Exactly. Exactly. So Verna, just so you can catch up, we got into billing questions, did some pop quizzes on minutes and what they can use with that, and just started getting into a bit more of the target population, some considerations, target caseloads, one to make sure that we can pay for salaries and also for appropriate care for our patients. And I haven't gotten into site consultations yet, but we just had a question about some of the interventions or what some of the clinical approaches would be for the behavioral health care managers.
Oh, awesome. Yeah, I don't actually introduce the PHQ many times, or the GAD, because I do it as a question. So if it's the first time I'm talking to Danny, right? First of all, I don't do them in order because that seldom works. And then I say, so Danny, I'm really glad that we had a chance to meet. I can see in your chart that you're really, you talked about having difficulty sleeping. Tell me about, your difficulty sleeping. So I ask, and then maybe just play it through with me, Danny, here for a minute. I'm going to put you on the spot, but you and I probably have done this before. So tell me a little bit about your sleeping.
Well, I mean, one, I struggle to fall asleep. I just start thinking about everything I have to do. And then once I do fall asleep, I'm waking up a lot. And
So
I'm
it
awake.
sounds to me like sleep is really a problem for you and you're not getting a good night's sleep. Is that like most days? Is it, several days a week?
It's probably a majority of the time.
So it's pretty much almost every day.
Yeah.
And tell me a little bit. So you mentioned that you have difficulty falling asleep. You're thinking, is it because you're worried about something or?
I'm worried I'm going to forget to do something. And I'm just thinking of like my checklist for the next day. So it's
Mhm.
just running through my head, checklist, and trying to make sure that I don't forget anything.
Yeah, it's always hard because we're all so busy, right? That it's always hard. Everybody thinks they're going to forget something. I'm wondering when you think about your sleep, has there ever been anything that's worked for you? Like how long has this been a problem for you and has anything been helpful for you?
It gets worse when the kids have all their activities and I'm busy at work. You know, I feel better when I work out, but then I don't have time to work out. So then it's just,
Mhm.
yeah, a moot point.
So how long would you say sleep has been a problem for you?
Probably for like at least the last year.
Okay. Sometimes when people have difficulty sleeping, they also have difficulty concentrating. Do you find yourself having difficulty concentrating on things, during the day, like if you're watching TV or reading?
Yeah, like it's like when I'm cooking and I remember I need something from the bedroom, so I go over there and then I forget what I need or I get distracted and leave like three things undone.
Mhm. So it sounds like concentration is a problem for you. Is that many of the days?
Mostly during the week when I'm
Mm-hmm.
supposed to be getting stuff done.
So when I hear you talking, it sounds like you're having difficulty concentrating and you get distracted easily. Tell me a little bit more about being distracted.
It's I think I just have I want to do everything, so I'm trying to start and do everything, but then I feel like I need to get more stuff done and then I I find that I don't get things done. So because I'm so distracted, I don't finish what I'm doing.
Mm-hmm. And has there anything that's been helpful for you in the past?
When I get a good night's sleep.
Mm-hmm.
Mhm. But that
You
doesn't
get
happen.
a good night's sleep? Okay, so it sounds like sleep is really a problem for you. How often do you find that like you're having difficulty finishing a project or making sure that, like particularly if you start a project and you dig the big pieces, how often do you find yourself not paying attention or not finishing the little pieces?
I get it done. So just not always when I want to. So not all the time, but I'm a some of the time.
But some of the time. And do you have difficulty, like if you have to do something, do you have difficulty completing all of the pieces or? uh,
No, I guess it's my type A that I'm double checking everything. So I make sure I catch it, but
mhm,
maybe
mhm.
not.
Okay. Tell me a little bit. I know sometimes it can be hard, like when you have trouble sleeping, that often affects your eating during the day. Tell me a little bit about how you're eating.
Yeah, I think I get so distracted that I forget to eat and then I get so hungry that I just eat whatever's in front of me in that moment. But yeah.
So you find yourself overeating sometimes.
Yeah.
Okay. And sometimes, I'm wondering as you think about what you're experiencing every day, it sounds like, trouble sleeping, some trouble concentrating, not really getting on a schedule around your eating. Are there times when you find yourself feeling really sad or?
not too sad. It's just a little bit frustrating wanting to get everything done, but not exactly sad.
Mm-hmm. And are there times when you think you feel anxious?
I think I'm more anxious or worried about not being able to finish everything.
Mm-hmm. Okay, so we're gonna just stop there. And so sort of off the top, Danny, you know, me not having enough cappuccino and coming off something else, and Danny, you know, getting thrown into it. But, you know, essentially, I don't actually ask the questions in order. I didn't say I was doing a PHQ. And actually, I asked a couple of questions from the ADHD adult screen, right? Because what I heard was, you know, like, is she really having some difficulty there? Like, I was ruling that out a little bit. I've only had difficulty sleeping for about a year now. Sounds like it's more what's going on than like some sort of a sleep disorder, but things haven't really worked. But sounds like she maybe hasn't tried some things, right? It's not, it's a little bit more anxiety. I have trouble falling asleep versus I fall asleep and then wake up, right? So then I asked a little bit more about anxious. And so kind of toggling back and forth a little bit. And sometimes if she hadn't really said I'm more anxious, I'll ask people if feeling sad or feeling anxious were in a race, who would win each day? Right? Like who, you know, where would you see that going? And so, you know, or if you were sad, would you still be anxious? Or if you were anxious, would you still be sad? Right? Like, so that you're really, and so I don't necessarily start, the reason I often start with sleep is because then when I start to ask some questions, I'm like, oh, wait a minute, this could be anxiety. And I'll switch over and ask more questions from the GAD. So that does a couple of things. One is you're kind of doing some discovery, but also I'm not doing both tools, because if I did a PHQ and a GAD on Danny, and Danny scored a 20 or a 15 on anxiety, right? And 12 on the PHQ, then I have that 12 sitting in my data, but she's really anxious. I'm going to start there. And so try not to necessarily do them both if you don't actually need to. And I'm also, so I'm thinking about a diagnosis, because part of this initial discussion is a diagnosis, right? And then also what's worked in the past, because maybe Danny could say, well, I used to do X and now I don't. So then I want to make a note, because maybe we could go back and do X, right? I used to read before I went to bed, you know. And I'm also getting ready for my psychiatric consultation, because I'm going to say difficulty concentrating. I ruled out ADHD, has difficulty falling asleep and staying asleep, hasn't ever tried any sleep medications, been a problem for about a year, right? And so then I have some information. Doesn't really have an eating, not really any eating disorder. It's more around, I have so much to do and I get wrapped up in that. I eat too much and then I get really hungry. So it's more situational than it is something that could be like an eating disorder, like a binge eating disorder, right? So, you know, so that's really how some of that initial conversation goes. There are times when someone doesn't really engage, and then I say, listen, there, we have a way to measure how you're feeling, like your blood pressure. And so then I will tell people, so I'm going to ask you some questions, right? And then we can measure. And it's really important that your provider know how you're doing. And so I think that often can be helpful. And then as I move forward, I will tell people, you're hearing me ask some of the same questions. We're using that to really measure how you're doing and set some goals. I kind of move them into it, but I don't always start there. I almost start with the questions and the discovery and kind of engaging them. And then I move into telling them really what we're doing. And I hone it down a little. So I saw Tisha put in the chat around using them. So Tisha, I would be a little bit more prescriptive around like several days, more days, but there is nothing that says you have to ask the questions in order. And so I think that that is the key, that almost always we find that it's better to ask the question and then do a little discovery. And that's not only engaging, but then you don't have to go back and say, well, tell me more about your sleeping, because you didn't have enough information for your psychiatric consultation. And I think that's the important piece. What do I need to know around each of these that would be helpful for my first psychiatric consultation that I should ask as I'm kind of going through? And I think that's a really important take-home message.
One question I have is sometimes the screeners or these instruments might be given with the paperwork. So someone checks in, we're giving them the PHQ-9, we're giving them the GAD, patients filling them out. And oftentimes when that would happen, I would then kind of have a picture, and then I would start to hone in based on the responses. And then I would do something similar to what you're doing. And sometimes patients would stay, you know, their answers would stay the same, but sometimes as you start exploring them with that, you start hearing different answers. And so that might be a way to capture both. Here we
Mhm.
are getting these baseline numbers, but then we're
Yeah.
all gathering more information. So when we're doing our case presentation, we're prepared and we have that picture.
Yeah, what I will also do is, as I'm going through, if they score a 2 or a 3, I'm moving that over to a care plan and something we're going to pay attention to. If it's a 0 or a 1, then I want to say, have you ever done anything? Have you ever had a problem? So if Danny had said, nope, I sleep like a baby, right? Then I would say, well, has sleep ever been a problem for you? Well, it used to be, but now, you know, I take melatonin and I read before I go to bed. So I say, okay, well, one of the things we're going to be doing, sometimes people who are anxious have trouble sleeping. So we're going to be making a list together of things that work. So I'm going to put reading before bed and melatonin on the list, right? Because it sounds like you've already solved some problems, you know, like you've already come up with some solutions. So let's think about some solutions for these other things that you're still experiencing. And I think those are important discussions to have. So I kind of focus in on the 3s and the 2s when I'm going over it, you know, like here's the biggest problem. Let's start there. And then asking some other questions. And I think, you know, asking them in a different order and having some discussion in between doesn't make them less valid. It doesn't make the tool less valid. You're still asking the questions. You're still, you know, giving them that information. You're still narrowing it down to those timeframes. And I think, you know, that's the important piece. You really want to have it. And one of the things that often patients, I hear from some patients is, I don't want to, they always ask me the same question. I don't want to do that tool. I don't like this. That's a training issue, because then they don't understand why they're answering the questions, and it's not getting used as a foundation for the discussion, so that it's being used as something meaningful in that discussion. And so if it's perfunctory, that's why when I hear places say, oh, well, we have to do the PHQ once a month, well, then you don't really get collaborative care. Because if you really got collaborative care, that would be guiding you. You'd be focusing on those symptoms, and maybe you wouldn't be getting through the whole tool each time, but you would be focusing on a symptom and using it as a foundation.
Okay.
So does that make sense to people?
Absolutely.
Yeah, I mean, you gotta, you know, really, and also it's really frustrating for the psych consultants to say, well, tell me like about the sleep or about this or that, and you don't have that information, right? That you've ruled some things out.
And oftentimes before the consult, you've already had the discussion with the team, right? That's
Yeah.
already happened. So you already kind of know what you're walking into. I mean, would that be correct?
Yeah, yeah. Mm-hmm. And
How
if
are
I
you
look
doing?
and I see insomnia on the chart, I'm really going to dig into that, because is that an anxiety problem? Is it really something else going on? Like, what is that? I'm going to want to know, because oftentimes what gets put in the chart by the providers isn't actually accurate. And a lot of what you're going to be doing is redoing that diagnosis. They might put depression, NOS, or anxiety, and they might have put depression for Danny, and it's not depression, it's anxiety, right? And so we're going to resolve that depression. We're going to put anxiety. We're going to update that problem list. You know, that's part of what we're doing in that initial session, is sort of getting that diagnostic information.
And that perfectly segue to you, the behavioral health care manager, being able to identify the interventions or what they're going to be suggesting for the patient to do. Going back to the original question of some of the interventions or, handouts that you can give to patients to help them out with the symptoms.
Mm-hmm. Most of behavioral health interventions are 6 to 8 minutes. And so there's some really great videos on like alternate breathing, progressive muscle relaxation, some of the DBT skills, and you can actually watch them with people or teach them and then say, hey, I'd love to give you a call tomorrow and see how that went for you. So one of the things that's really helpful, and we can share some, I actually have some new pathways with some things and resources that you can actually do with patients that, and then, you're following up. So you're talking about a skill, you're teaching the skill, you're following up. Setting a goal, following up. Yes, we'll share that. Absolutely. So Danny, I want to thank you for jumping in today and covering and hopefully answered all of the FQHC questions. I think everybody will see why we call her Rockstar Danny. So I wanted to we haven't done a super deep dive into psychiatric consultation. And I really wanted to start with answering any questions about psychiatric consultation, or hear a little bit how it's going, and then try to do a little bit of a deep dive.
I can just jump in first, although I can tell you, I know we don't do it 100% the way it's modeled. Kim observed that this morning, and we had a few laughs about it. But what we are doing now is not one behavioral health consultant. It's kind of all hands on deck, and that sounds very disorganized. And we're looking to get more toward an organized situation. But we have a number of providers that work, and we have open times of the day. And so during those open times, that's kind of when we fill those. But it's not the consultation in the way that is described in the CoCM model. So what we're trying to do is figure out how to get from where we are now, which is a very informal process, to a more formal process.
Yeah, you're gonna need
sense.
Yeah, you're going to need to do that big time. The reason that the group consultation doesn't work partially is for billing. One, it's really expensive because I'm sitting there and you're paying me and you're not talking about my patients. So that's downtime for me, right? And so you want to, for psychiatric consultation, you want to then have that dedicated time so that I can say, we spent this time talking about this patient, and then it goes. And so I think that that's a really important piece, just that billing and tracking piece. And whenever it's a group like that, you wind up being less efficient and not tracking the time as efficiently. So that's a really important piece. And also for your Medicare patients, the model requires that consistent psychiatric consultation, like from a model fidelity compliance sort of place. And for your Medicare patients, you do have to document that psychiatric consultation was available. You do have to have a process for reviewing your patients that are not getting better or getting worse. And each care manager has to have that. So I would say moving away from that sooner as opposed to later is kind of a priority. And if you don't have high caseloads, then you could do 30 minutes, instead of an hour. At a full caseload of 90, generally it's about 90 minutes that winds up being psychiatric consultation, but you want to switch to that sooner as opposed to later for sure.
When you say 90 minutes, do you mean we're just trying to figure out how to structure the time because we're going to be pulling a provider away from from traditional behavioral health to do this. So if we're structuring that time and we're going to be blocking that time, and right now what we do is very unofficial and we don't bill for that. It's just a service we provide to our medical providers. So what would be a good estimate for starting to block that time and how much time? And we would
Yeah.
be looking, just to give you kind of an idea, we have 17 sites
Yep.
that would, so, but we're looking to get started, I think, in one site, but we're
Mhm.
still going to need to provide support to those other 16 sites. So
Oh,
that's
yeah.
where we're at. So if you've got any guidance or tips on that, that would be spectacular.
So here's some thoughts, as you expand, if somebody has like half a caseload, so they have, 40 patients, 45 patients, you could do 30 minutes a week if you're super efficient. But once they get up to a full caseload of 90 patients, you're probably going to need 60 to 90 minutes per care manager. Like 60, they have to be super efficient. And so if you have 16 care managers, that's going to be 16 hours a week for a psychiatric provider. Now that time is figured into your pro forma. So it's covered in the reimbursement. So even though you're not billing and getting your PPS rate for that time, which arguably, if someone saw 3 patients in an hour and you got your PPS rate for all 3, then yes, right? So, but if you're doing a straight pro forma where you're looking at the time that you're paying them for that time and you include it in the pro forma for collaborative care, you're likely still going to come out ahead. If you count in lost revenue, I don't know, that gets a little dicey. But I think that's the model. Generally, a full-time psychiatric provider can have a caseload of like 25 to 30 care managers, like if it's their full-time job doing psychiatric consultation. And so I think that's probably the way to think about it. What some FQHCs do is they actually will contract out. There are some providers like Ascend that specialize in doing psychiatric CoCM for FQHCs. And then that winds up being a little bit cheaper for them. Like if you're going to do it at volume, if you're going to do it in 3 sites, then I would say no. But if you're going to do it in 16 sites, that starts to be pretty much somebody's full-time job.
And that's okay if it is. We just,
Yeah.
it needs to make sense.
Yeah, so a full-time FTE care manager would have about 90 cases, which would be at least 60 minutes of psychiatric consultation each week.
So Verna, when they're starting, the thought is they'll start with one site with the provider. How much time do you think the psychiatric provider would need for the one site as they get started?
I would say one site, one care manager, 30 minutes a week, but you want to ramp up, in the first 3 months. And so I would say 30 minutes for the first 2 months and then 90 or 60 minutes after that, assuming you're ramping up like you need to.
We will ramp up quickly. We've got an identified group of patients. So
yeah, and you want to be at that 90 patients in the 3rd month.
I think that's realistic for us.
Yeah.
Question I have, and I heard this on the Ames office hours last week. Their psychiatrist was talking about, the amount of time they were spending with the BHCMs to do the case review, but then also had some time set aside specifically to do some more in-depth consultations with PCPs. Do you see that happening, and or are you ever seeing them see a patient and then refer them back into CoCM? If you could just talk a little bit about how you can see them used besides registry review.
So there are some times now where they're doing consultations for people not in CoCM, and they're using the interprofessional billing codes to do that. Or they're seeing, so what is not a good model is that they get referred to the psychiatric provider, they see them for one visit, and then they go into collaborative care. That is not a good model. What is possible is that if someone is more complicated, if somebody maybe has a treatment resistant, or there's a real diagnostic question, or sometimes people are more likely to do this with kids, they could see them and then make the recommendations to the psychiatric or to the primary care provider. So they could see them, make recommendations, they would bill the E&M code for seeing that patient, and then they would stay with the PCP in primary care and collaborative care. So they could see them for a one-time, maybe twice stabilization, transition back to primary care kind of thing. That generally tends to be, there are places, particularly with kids, where they will prescribe the ADHD meds, they'll stay in collaborative care and see the PCPs. A little wishy-washy for collaborative care, but some places do it with the peds.
Yeah, I could see that working actually, because you have these requirements where they have to see an MD ever so often. And
Yeah,
most of ours are, psychiatric nurse practitioners. So
yeah,
it would help to fulfill that requirement. Would let you kind of
Yep.
keep up.
Yeah,
with them
that's
in between.
exactly right. Yeah.
And we also do that some we have a number of school-based health centers. And so we have some new legislation in Arkansas and that requires it's called the LEARNS Act. I don't know but it requires students that, they could share a meme that looks dodgy and they would be required to have a mental health exam before they came to return to school. And so we do a number of those where we would send them over to psych to evaluate, and then for that school required component so that they could get back to school. And then they may not need additional psychiatric services, but they would need to be followed. And that's another group we're looking to grab. So
Absolutely. Yeah. I would say absolutely. Also, sometimes people need a psych eval for like housing or some other, thing. So yeah, they do that, but they stay in collaborative care. Yeah. Yeah. Absolutely. Yeah. And I think, those are some of the things, particularly around peds, you see those workflows more. What's going to be super important is to make the psychiatric consultation efficient. And, I know for me, I was not trained to do a case presentation at all, right? Like nobody ever taught me how to do that. I unfortunately got thrown into a medical practice that was also teaching, and, I learned they taught how to present to the attending. And so a good way to really practice is to say, okay, here are the people. So here's some patients that are at risk, they're going to be first. Here's some people that have gotten worse, right? Here's some people that have gotten worse, right? Their PHQs, their GADs, whatever tool you're using has gotten worse by more than 2 points, right? So we're going backwards. And maybe it's not because there was a death or some other thing, right? So that actually, and then people who are not getting better. So if I'm caring for Kim and her PHQ hasn't changed in 3 weeks, she's not getting better, we're going to make sure we're talking about her. Anybody who's having side effects that are really impacting their medication support, right? So we're going to prioritize those people and anybody that the PCP wants to talk about. So we're going to prioritize those people. Oftentimes what we find ourselves doing is we're over talking. So a good way to practice for psychiatric consultation is now we all have a timer on our phone, right? You know, is you go on your phone and you set it for 60 seconds and you then practice presenting. And you make sure you get it in that 60 seconds. And that will help you really be concise, because a lot of times we're saying things that a lot of any psychosocial background, we don't need to bring that in. And if they need it, they'll ask. So like, are they employed? They might ask that because can they keep a routine? Have they been able to do that, right? But most of the time, you really want to be, patient is a 58-year-old female who presented originally with a PHQ of 20. Patient has been in care using goal setting and some motivational interviewing now for a month. PHQ has not changed. Patient didn't consider medications, is now interested in maybe starting on a medication. Primary care provider would like a recommendation. Patient reports she is very concerned about gaining weight and is not going to take any medication that she thinks is going to, cause any weight gain. Patient has a history of depression for about 12 years, reports not any time when she felt like she hasn't been depressed, is having difficulty sleeping, falls asleep, does not stay asleep for most nights, finds herself overeating pretty consistently from day to day, has gained about 40 pounds in the last 9 months. So like very specific, sleeping, eating, history, what are we thinking? And where did we start? Where are we now? And what is that time frame?
I
So
think
we
that
tend to,
the registry rent, it linked to that whenever we did like the spirit study, like you have this score, then this score, and this is where we're at, this is the problems, or we're good. You can kind of like flag them accordingly. We're going to have to build something for that.
Yes, and actually I'm involved in the new spirit trial now with bipolar and PTSD. So I have pathways for bipolar and PTSD if people want them in collaborative care, and you can certainly do collaborative care with them using the PCL for trauma and the PMQ and the PHQ. Yes, I will send them. Actually, Kim, I'll send them to you. And then you can share them out with everyone. They're very pretty.
I know, Verna, you've been doing so many things, and when I see them, they are beautiful, and I think, wow.
Oh, these are so pretty. Yeah, and they do have consistent with the spirit trial. So there's a lot of thought about people with bipolar getting a psychiatric consultation, at least one for a diagnostic confirmation. So that is here on the pathway that I'll share. It's not necessary. It's a little bit more consistent, which was done in this sort of big spirit trial. So you can kind of pay attention to that or not. But it'll give you some thoughts on the rest of it. And then you could have this, and you could modify it for your own practices.
Awesome.
So how does that feel? A lot of times for psychiatric consultation, we really present. Patient is a 58-year-old female. She lives with her husband and a grown child, and she lives in South Carolina, and she has a high school education and a doctorate in, psychology, and she works as a, psychologist. Nobody cares. Like, that's a lot. Not that nobody cares, because people care, but like, not for your psychiatric consultation. It's too much information that doesn't need to come in. So that's why we don't do these big biopsychosocial intakes in collaborative care, right? Because that's not the information that we're using to kind of move care forward. And so we want to really stick to some of those parameters. The sleeping, the eating, particularly the history. When have you felt this way? When have you not felt this way, right?
what's been helpful, those kinds of things.
What's been helpful in the past. And a lot of times people will say, and this is where a lot of times, if you ask people what's been helpful in the past. So I had someone the other day and they were like, well, I haven't been on medications because I haven't had insurance and I've just been feeling worse. But I was on a medication before and it helped a little, but it really didn't help very much. So what medication were you on? I was on Lexapro. Well, tell me about how often you were supposed to take the Lexapro. Well, I was supposed to take it every morning and every night. So tell me about the times when you weren't able to take the medication. Like, how often did you not take the medication? So after a discussion, we realized, and sometimes I've done this with 3 or 4 different medications, patients will say, I tried everything, nothing works. But then when you actually talk to them, you find out that they've never actually taken any of those medications as prescribed. So in actuality, we don't know if they work or not because they've never actually. And so if you go to the psychiatric consultant and you say, well, they've tried this, this, and this, and none of them worked, that actually may not be accurate information at all. And I tell people, like, it is really hard to take a medication every day. But with, you know, medications for anxiety, it's really important to know. So tell me about the times when you didn't take your medication as prescribed, right? And it's cool. Let's talk about it, right? You know, if you're supposed to take it twice a day, like I know for me on the weekends, I forget to take my meds. So, oh yeah, actually, you know, when I would travel, I didn't take my meds. You know, were there times when you took like more of your med or less of your med on purpose? Well, yeah, you know, I would take more of it on the weekends because I really like to sleep good, but I wouldn't take it on days I was meeting with my boss. And so, or I wouldn't take it when I was going out because I was going to drink and I didn't think that I could drink with the med, right? So you find out that actually there was all of these things happening that they didn't actually take it as prescribed. And maybe it didn't matter, but maybe it really did. And then to say, you know, when you talk to the psychiatric consultant, well, no wonder it didn't work, right? Or that was probably enough. We know we're going to try something else. So it's important to kind of do a little bit of a deep dive there. So when I ask people, well, tell me, it sounds like you've been feeling sad for a while. You know, what's been helpful? If they say medication, what med? And then I do a deep dive. I do it right then and there.
So let me ask this, and I just have to say, I know you said 60 seconds, Verna, and yes, we all have smartphones, watches, but this is the South, and I will say, you know what I'm doing.
I live in
that
the
you said
South
this.
now. I'm in South Carolina. I count.
That's right.
I
It is-
count.
I'll just say it could be a little challenging for 60 seconds. So I'm going to say maybe it's 120 seconds.
Or 90 seconds and we meet in the middle.
90 seconds.
You would be surprised how much information you could
Oh,
put
yeah.
in there. And what's really good is to practice and then have someone say, well, this is probably, but what about this?
Okay.
Right. So, but that's like to really try and have someone say, okay, that information can come out, right? Or what about sleep? Or what about eat? Or what about a history of meds? So that you can kind of say, oh, you know what? I didn't get that. Right? Let me go back and get it now before consultation so that you practice a little bit before the first time.
And I think sometimes the shorter is actually helpful, or that was my experience with people. You know, you're going to take just a couple of minutes of their time. So it's not as impactful on where they're at and like what they're doing. They know they're going to check in and you're going to be able to be like, hey, you know, last time we talked about this, is that better? Tell me a little bit about it. They do. Hey, you have anything else that you want to talk to me about this time? Because I think we have a couple days and I'll check back in with you. What do you think about that?
Yeah.
You know, and keeping it brief, like for me as a human, that would be essential. But a lot of people like that too. You have these small touches and that's why the 5 minutes at a time really matters.
It does. And, you know, one of the things we know, and I know you've heard me say this over and over again, and I just looked at it again, and I think I've talked about this across 40,000 patients in collaborative care. And what mattered the most was the number of contacts. It was not the amount of time. If I talked to you 10 times for 5 minutes, you were going to do way better, have a way better outcome, and have way better engagement than if I talk to you every week for an hour. It is the number of contacts, particularly in the first 2 weeks of care, and particularly the time frame between that first contact, but that is what matters. And it's those short touches that really make the difference. It's the number of contacts. And think about it like doses, right? You have to give someone enough doses to get better. If somebody doesn't get enough doses of treatment, they're not going to get better. You're not going to see a change in those symptoms.
I love this, Verna, this explanation of, you know, these initial contacts and giving this high concentration of these initial contacts, because you think about really it's developing a relationship with people.
Exactly.
And developing this relationship rapport. They're now trusting you. And when something's wrong, they're going to tell us. And I think for me, and especially when I've been starting out and doing, you know, different roles than BHI, it's the patient doesn't know what we should or shouldn't be doing. So if I don't ask these 3 questions the right way, they don't know. So as long as I have a way to start that relationship, build on that relationship, engage, they feel heard and trust me, we're going to get a lot further than, well, did I use MI the way I learned from, you know?
Yeah, I think that that's completely right. I also think it's just helpful if you think about it, even in your own life, right? Something that you really want to do, right? That you've been like just not able to get done. And somebody said, like, what's one thing you could do towards getting that done today? And then said, I'd love to give you a call tomorrow and see how that went for you. What's something else you could move towards that, right? And it doesn't matter. Think about cleaning the garage, doing your taxes, exercising, like it doesn't even matter, right? Getting a better night's sleep. If someone worked, if you really took a problem, solved it every day, and then had someone following up with you and say, it didn't work, what else could we try? Oh, that worked, what else could we try? And they were doing that every day or every other day. Think about how successful you would be at that. Like that would really be, I got about 6 things that would be really helpful for me, right? Including sleeping. And so, you know, those are the things, right? Like that would be great for me. I should probably put myself in collaborative care. But I think like that helps me really imagine the impact that I could have on someone else. Because it's like having your own cheerleader every day.
Don't patients kind of get trained to what you're going to ask? So it goes
Oh, yeah.
short the next time, like they answer the phone and they know it's you and they're like, hey, I'm sleeping better. Hey, and then you don't even have to ask the questions. I mean, that's been my experience anyway.
It is. And they'll say, oh yeah, I tried, reading before I went to bed and that was super helpful. And they say, well, tell me about, sleep. Then it sounds like this week, it's gotten better. We went from several days to this. I'd really like to see us try to come up with something else so that sleep isn't a problem for you most days, right? So like, is there something else you think you might be able to do? So then I build on it, right? And then follow up, or maybe we move on to something else. So yeah. And also when I'm setting a goal with someone, I find myself saying, well, what's something you might be able to do towards your goal of whatever? And then they say whatever. And I said, well, what might you do towards your goal of whatever? And I probably say that 5 or 6 times. And I say it intentionally like that. And eventually people are funny. They go, well, you know what I could do towards my goal of, or you know what I could do? Like you see them partializing it down and, and they're having that conversation with themselves in their head, right? and they're talking about it, but that's exactly what I want, right? I want them to then have that skill to partialize it down so it's doable and manageable. And you'd be surprised how people pick that up. Like after about 2 weeks of doing that, or week of doing that, people are like, oh, I get what this is. Yeah. But yeah, you're absolutely right. They pick it up for sure. And you know, if you hear feedback from site consultants, they will say sometimes, oh, for the love of God, get to the point. And I think, and you know,
Absolutely. Yeah.
I've heard that a lot, like that, you know, care
I'm gonna
managers.
second that, Verna. As the recipient, I'm gonna second that.
Yeah, you know, and I think that that's, you know, and I was being probably a little harsh, but that's the most feedback that I get a lot of times from site consultants. Too much of the wrong information, right? Too much getting to the point, and then not enough information for them to do a consult, right? And also I try to think, what do I need from the psychiatric consultant? Do I have a diagnostic question? Do we need to do something with the medication, right? So are they going to need to start or change a med? So then I also focus there. They've been on the med for this long, right? And they're having these side effects. This is the problem. So I'm going right to whatever it is, or I'm struggling with the diagnosis because of this and this. So then I will just jump to whatever that is, you know, whatever it is that I think, you know, I need from them. But yeah, and I would practice. And I would practice with each other and then say, okay, these are the things that you don't need to do. And you just spent 3 minutes talking. And it doesn't mean you're like unfriendly, or it just, what that does is get you really good at being concise and getting right to the point so that you can be efficient and that your psychiatric consultant can do what's needed. If you don't give them the right information, they can't make a consult. I had someone recently and they did 13 consultations in 90 minutes. And the psychiatric consultant couldn't actually do a consultation on 7 of them because they didn't have all the information that they needed.
Yeah. Great point. I think getting to know the patients and actually doing the intake will also help with being more efficient.
Mm-hmm. Any other thoughts, questions about psychiatric consultation? We hadn't really sort of done a deep dive, and I wanted to just give it a little attention today.
So I just want to make sure I have this right on my brain. Like, so primary care identifies the need and they, you know, consent, and they send this referral to services. Case manager reaches out. They also schedule the psychiatric consultant for an initial psych consult of this patient. Correct. And then the case management starts and they start having this in between.
No,
I didn't think so. Okay.
Okay, so here's what would normally happen is I would be a primary care provider and I'd say, listen, you talked to me today about how anxious you've been feeling. And I work with Kim and she's on my team and she helps me care for my patients who are anxious. I'd really love for her to give you a call later. Is that okay with you? Yeah, absolutely. Kim can give me a call later. Good. There's my consent. And then I would put the referral into the chart into Kim. Kim would give a call later. Hey, I see that you were in to see, you know, Dr. Conway earlier, or provider Conway, and you talked about how anxious you were feeling. Tell me a little bit about anxious, you know, and then I would ask some questions from the GAD. I would ask some sleep. I would get some information, right? Have that conversation. And then maybe I would put that patient on the list for psychiatric consultation, or maybe not. Maybe I would start care and we'd set goals and I'd kind of see where it went. They're on a med, they just started on a med. They're, you know, we're going to see how the med works. We're starting to do some things to feel less anxious. I don't need to bring that case to psychiatric consultation.
So there are going to be situations where they just kind of actually have case management do well. Then they roll off after their period of time. They don't really have to be like medicated, anything like that. So
yeah, absolutely.
I have that right in my diagram here. I just have to clear it up. in
Yeah,
my
and
brain.
even if they are on meds, right? They get started or they're on meds, they still may not need a psychiatric consultation because maybe the meds are working.
But they'll still be on the registry.
Yes.
Yes. My
And
brain is just like, how do you allocate, if you're gonna have a site consultant that's also a regular provider, how do you know how to allocate time for site consults? But it's gonna have to just be as the need arises.
Well, I would actually say it's basically gonna be by the volume of patients. If you have a caseload of 90, you are inevitably gonna have 10 to 15 patients at any given time that you're bringing to psychiatric consultation. Like, that's just the numbers of it, your caseloads. Like, I know I sound like a broken record. You have got to build your caseloads. You are never going to figure this out with 3 patients. You are never going to get the population health piece of it. Your providers aren't going to get it. You're not going to get your workflows and your billing down if you don't build up your caseloads. You have got to get your caseloads full, you know, in the first couple of months. Like, that unequivocally will guarantee success.
one question that has come up, and that I'll ask you, the question is, if a patient is a patient of the clinic, they've been seeing a primary care provider, that patient, a nurse, through looking at maybe a higher PHQ-9, maybe it's a 15, says, oh, this patient might benefit from CoCM, let me schedule them. But that PCP left, we have a new PCP. Can they enroll them in the CoCM model prior to having a visit with the new PCP?
They can, as long as that PCP puts a referral in.
Okay,
The clock does not start until the PCP puts the referral in.
that's helpful.
Yeah, and that's why, like, if you have a provider that leaves, you want to make sure that the new primary care provider puts a referral in, because that old primary care provider can't be the billing provider anymore. So you want to really make sure that if you have a provider leave, or I would say somebody goes on vacation, doesn't matter, but if somebody goes out on maternity leave for 3 months, then oftentimes organizations will have that covering provider put a referral in.
One of the things that I hear and I think is important when I'm thinking about the BHCM, we often hear, they're the patient's advocate, they're the eyes and ears really of the team, they're the glue, they're communicating back and forth. Anything that's happening with that patient is getting communicated to the psychiatric provider is making recommendations, BHCM's following through, the PCP is prescribing. Just want to make sure we're all
Yeah.
page.
I would say, to a question that comes up sometimes, is how often do I keep the PCP in the loop, right? Like, what's important for me to tell the PCP? So I will say they have access to your notes. They can read them or not, depending on, them. But I would say when someone enrolls, so I will send them a note, patient has engaged in care, so that they know, hey, I got them, they're on board. Or patient didn't respond to outreach, I'm taking them off the registry, please let me know, we can refer them, or maybe next time they're on site, let's do a warm handoff and I'll meet them, right? Or if there's a change in risk, patient has come off the suicide care pathway, patient has changed risk levels on the suicide care pathway, patient reported significant nausea from medication, I'm going to discuss it, psychiatric consultation. So side effects, changes in risk, enrollment or disengagement, or, coming off the registry for some reasons, like those very key kinds of treatment milestones, I would say I communicate separately. And sometimes providers have told me, I don't want to know if you put them in care, just tell me if you don't. Okay. I would say one of the things around case finding too is, for those of you who do Medicare work or ACOs, they have this thing called missed opportunities. And it's really helpful when you first start doing collaborative care is to go back through the provider schedule and say, hey, here's this person has depression on the problem list. We haven't done a PHQ in the while. They're on meds. We don't even know how well they're doing. I don't see anything here. Like, that's a missed opportunity for collaborative care. Would you like to put a referral in now and I'll follow up with them? Here's someone that came in, they're feeling very anxious about their pregnancy because they've had a miscarriage before. Here's a missed opportunity for collaborative care. So that you actually go through and point out the missed opportunities. And then I ask them, would you like to put a referral in now and I'll give them a call.
Mm-hmm.
And so not in a blaming way, but like in a, I was looking at your schedule and here's some folks that I think I could be helpful with. And, let's go through and pull them up. And then, they could go in and put the referrals. That's a great case finding. Or nursing. Anytime somebody calls in for a refill of depression or anxiety meds, do we know if this med is even working? A lot of times you do a PHQ or GAD and they're still very symptomatic. So then we need to do something different. We need to get a psych consultation. We need to do something different.
Absolutely.
So maybe nursing does what they always do, but then says, listen, we have Kim on our team. She's going to call you today and ask you some questions because your provider really wants to know how well this medication is working. She's going to call from this number. If you could just pick up and answer some questions.
Yeah. We got into the weeds. I feel like we really did a great deep dive into the billing. I'm excited about that piece. I think we have a good idea of the care team. Danny showed us some workflows that were great and I think helped us get a better visual. Anything else? And just to kind of let where we are, Verna, because I know you're working with other states that are also doing this project. What we've done in Arkansas is we've really spent, well, we didn't get going until probably, I don't know, maybe March, April-ish. So we really haven't been going that long. There's a little bit of a slow start, but we've been spending our time laying a strong foundation. And so we have done a intensive training series on what is the collaborative care model? What does it look like? The different pieces for the care team, how to identify patients that will be participating in the CoCM model. All of these things need to be in place. We have to have our teams in place. We have to have people trained. We have to have a workflow before we start the billing piece, because if we don't have patients enrolled yet, we're not going to be billing. So we've spent time doing that. We'll now go more into specific skills training for the BHCM and then supporting and coaching them as they're getting out and doing the work. When you're looking at other states, how are they doing as far as this?
Yeah, I think some are farther behind, some are ahead, in terms of having done some clinical trainings and some things for the care managers. What I would say when I think about skills, it is so important to know the treatment choices. If you don't really understand the treatment choices in collaborative care and that people can move through them, and that you don't give symptom monitoring to people as a choice, that is going to be a really tremendous problem. If you find yourself scheduling people at the same cadence or then you've drifted. And the other is the goal setting. Probably 90% of the time, I do the goal setting and like that feel worse, do less, right? Do less, feel worse kind of thinking. And setting these small manageable goals and then following up. And that works. Honestly, it's really like magic. It literally is magical. But the ability to get down and really partialize that goal down, I would almost guarantee or say that 98% of the people that set the goals for the first time set too big of goals.
Mhm.
And so something to really is to literally say what's something you could do towards, and really say, if you haven't said that 5 times, you probably haven't partialized the goal down enough.
Okay.
Like somebody said, we'll stand outside and breathe some fresh air. First of all, SMART goals. We don't want to do any SMART goals. If we have something, I'm going to stand outside 3 times a week. I'm going to exercise twice a week. No, that's too big. Too big. So you want to, if you have yourself doing it multiple times, it's too big.
Okay. So let
So
me
that
ask,
might be something if you ever wanted to do like just a separate little time and like talk about some goals, have people bring goals, role play it, do that. More than happy to do that.
okay. That's something year 2 will start. Because I think it's really important, when we're thinking about that high concentration of touches, right, those first 2 weeks, if we set a really small goal, which might be, I don't know, one of the things I heard you said was, I'm feeling sad. And when's the last time you opened your blind, you sat by your window, opened your blinds when you had your coffee? How did you feel when you opened your blinds and drank your coffee?
And celebrate it. What did it look like? How did it change the room? What did you see outside? Like, we are celebrating. How did it feel to meet the first goal? Like, we are excited about this, right? Yeah.
Absolutely. And then following up that next day and then really engaging with them. Wow, you could feel that little bit of a lift when you were looking out your window and you saw the birds, and this is so exciting. And then helping them set another small goal.
But exactly, right? And I've also been on the phone while someone's opened the window blinds.
Yeah.
And they say, well, I could actually do that now. Great, let's do it. That's why the telephone is so important in collaborative care. Let's go outside now and take some deep breaths. If your goal is to look at your garden, let's do it now.
What does your garden look like?
Yeah, I'm going to stand outside and just look at it because my wife died. I haven't been outside. I haven't looked in the backyard. We used to garden together. So the goal is just to look at the garden. Let's do it right now.
Absolutely.
Yeah, yeah.
Thank you so much for talking about that, because I think it's important for us. And I'll just say, sometimes, there's the emphasis of, there are these evidence-based practices, and yes, they're important. However, we have to really drill down to very, very small, specific, develop the relationships, have something small, attainable. Let's celebrate together and then move to the next step.
Yeah.
Okay. Well, anyone have any questions about that piece and about how small we can start with this model? Okay. I know people are having to hop off. It's getting late. Berna, I can't thank you enough for your time walking through this
No
with us.
problem.
It has been absolutely phenomenal. I continue to learn so much every time I'm on with you. And thank you